this next segment, I'm going to talk about the encounter data files themselves. And yes, and a little bit about other files that contain MA data, but mainly the encounter research files. But I will talk about list, some of the other CMS files that contain Medicare Advantage enrollees. We'll talk about file structure, some of these files, contents, and do some comparisons with fee-for-service data as well. So encounter data are available in research identifiable file format, otherwise known as RIFs. There are no limited data sets or public use versions of encounter data like there are for fee-for-service. RIF files contain personal health information, otherwise known as PHI. So while most RIF data files do not actually contain direct identifiers like social security number or name, there's enough information that when you combine it, you could potentially identify a person if you knew someone's zip code and date of birth or date of death. You could potentially zero in on their records in a RIF file. So in order to protect member information, researchers must sign a data use agreement in order to use them. Researchers can customize the individuals included in the data. You can create your specific cohort by creating criteria based on geography, diagnosis, procedure, service, or other researcher submitted identifiers such as social security number or HICN. So the data can also be linked to external data sources if a personal identifier is available. CMS charges a fee for these files, and most are priced based on the size of the cohort and files and years you select. So a typical request involving all claims and enrollment for a 5% sample of the Medicare population would cost about $30,000 a year. All RIF requests require a research backbone. That is, there must be a clearly defined study with specific aims and objectives. The CMS Privacy Board review is also required. In all, the request process can take between 4 and 5 months. So the RIF encounter files come in annual format only. That is a little different compared to fee-for-service. I think we already talked about that. You can get quarterly fee-for-service files, not so for encounter. Managed care organizations have up to 13 months after the end of the year to submit encounter data to CMS. Thus there's a longer lag before the release of it compared to fee-for-service RIFs. This chart shows all of the CMS research data files that contain data for Medicare Advantage enrollees. You can see on the left, there are the same set of encounter files as fee-for-service, except for hospice. Hospice is paid. Actually, all hospice care, regardless if it's fee-for-service or Medicare Advantage member, is covered by Medicare. So it's going to be, all those claims are going to be found in the fee-for-service hospice file, which you can see over on the far right. Above the hospice file in the chart on the far right, you can see that there's the MedPAR. The MedPAR contains inpatient and skilled nursing facility stay records. And it does include stays for Medicare Advantage members. However, the records are not comprehensive. They're not as comprehensive as the fee-for-service records, and they do lack some of the detail that fee-for-service records contain. Part D.
Less comprehensive how?
I believe, information related to to payments will be lacking compared to fee-for-service data.
But you mean in terms of the content of the records, then not whether or not the event is present, but rather the level of detail about the event?
Yes. Yes, that's correct. Right. But I mean, there is some question as far as the completeness as well, of, you know, if it is, are all stays for Medicare Advantage members included in the MedPAR? And later in this afternoon, we kind of show you an analysis that we did comparing the MedPAR to Encounter files. So
Great.
that'll be maybe interesting for you.
Yes, thank you.
Okay. Part D files contain both fee-for-service and Medicare Advantage, as do the assessment data files listed in the chart. And of course, we already talked about the plan characteristics file. Linking within Medicare Advantage files has the same approach as for fee-for-service files. Benny ID is kind of a common variable that will be the same among the files. The Benny ID is specific to each study. CMS sort of, I think encrypts is the right word, Benny IDs differently for each study, kind of to protect the data so that it's not used in a way that was not approved. So you would need to use the Benny ID to link, help you link up all the data files you need to comprehensively look at all the care that was provided to an individual. For example, if you're interested in surgeries, you would want to look at both the inpatient and carrier files so that you can get the facility records and the physician records. So, so it's just, you know, we want to make it, make the point so that, you know, you need to know which types of members are included in each file, so that you know that you're gathering all utilization data, you know, needed for your study for your members. And so, you know, it's just important to know that some CMS files are limited to fee-for-service or to Medicare Advantage, and some files contain both. The files in the far right column of this chart kind of gives you a list of the files that would contain both types of members. So the encounter files, we'll kind of break it up between institutional and non-institutional files, because within those two categories, the files are more similar to each other. And, you know, it's kind of broken out the same way for fee-for-service. But anyway, so first we'll start with institutional encounter files. There are 4 of them. You know, this is based on care type, inpatient, outpatient, home health, and skilled nursing. It's the same as fee-for-service, except for one exception, that's hospice. Each file type comes with a base and a revenue center file. Another way to refer to them are the header and trailer files. So the base has you know, 1 record per encounter, while the revenue center file can have multiple rows per encounter. The way you link between the base and the revenue center file is using the variables, 3 variables: Benny ID, claim type code, and encounter join key. So you can see here, we were depicting that there can be multiple rows for a single encounter, multiple revenue center rows for a single encounter. I'd also like to mention that there are also 4 lesser used, what they call reference files. The condition, occurrence codes, span codes, and value codes files. You know, we don't really know much about the data in the reference files, particularly for encounter data, but you know, we just want you to be aware that they do exist, kind of have some brief description of what these files contain in the table on the right. You know, they kind of contain sort of like special events related to the encounter that may have impacted how it was processed. Various things like that. The way that you link to the reference files is the same as the way that you link to the revenue file. Benny ID, claim type code, and encounter join key. So the base segment contains you know, what you could say is summary information for each encounter record. Here's kind of a list of sort of like most commonly used variables that the file contains. It's, you know, very, you know, quite similar to fee-for-service claims data. You know, it has the beneficiary ID, claim dates, facility type, and it has MPIs of the organization, the provider's organization, maybe also MPIs for the actual physicians that did the care. Inpatient files contain DRG and derived DRG. So in the encounter RIF files, 000 DRGs, you're going to see those more commonly in encounter records, possibly because you know, there can be differences in billing policies and payment structures for Medicare Advantage organizations, which may mean that some of them don't use DRGs to process those services. So that's why it's more common, could be more common in encounter files. But there is a derived DRG that that is created during the RIF construction process. But according to the user guide, they say, you know, you should not use that derived DRG variable for inpatient rehab records or chart reviews. If you're wondering what a chart review is, I'll be talking about that later. And of course, it has, you know, diagnosis codes and procedure codes and dates, just like fee-for-service claims do. The revenue center file also is quite similar to fee-for-service files. There's one line per revenue center. There can be multiple revenue centers per encounter. You know, and it includes beneficiary, revenue center codes, line dates, and as we've already pointed out, there's no financial data. So here's a poll for you. So where do you find demographic information for members of a managed care plan? Give you a minute to answer the question if you would like to try. So yes, it looks like, oh gosh, 98% said the MBSF, and that is a good choice. So I'm glad to see that a lot of people would get their data from the MBSF. But I would like to say that there are demographic fields in some of the Encounter RIF files. But like I said earlier, we would recommend using the MBSF because it is highly reliable information. Should I click share results? Okay. So onward. So like I said in the beginning, we would show you some comparisons between Encounter and fee-for-service RIFs. Here we'll start with the percentage of beneficiaries with any claim or encounter by file type. And you can see that, generally it's pretty similar between the two categories. Medicare Advantage enrollees, you could say, are slightly less likely to have records across file types, but generally they're in the same ballpark. And then when we compare number of records per beneficiary, the left chart shows the number of records in the base files, and the right hand chart shows the number of revenue center lines per beneficiary by file type, excuse me. So again, fee-for-service and MA, have overall similar record counts. Encounters tend to have fewer detail lines per record. The one thing that does stick out here, like a sore thumb, is home health, which appears to have a lot more lines in Encounter data compared to fee-for-service. We're not
other way around.
Okay, other way around. Sorry. Yes, fee-for-service has more lines per record. Yes, right. So anyway, but we can't really say a lot about why that is at this time. But it could be driven by different billing policies between fee-for-service and Medicare Advantage organizations when it comes to billing home health. Fee-for-service required home health episodes be billed on a 60-day basis until 2020. Then it changed to 30 days. But the point being that MAOs may not be requiring home health agencies to bill in the same way. So it's just something that you might want to keep in mind when working with home health data, that you would probably want to dig into the data and get a feel for what's going on in it before analyzing it. I believe the data used for these charts was from 2019. So we also compared diagnosis, the number of diagnoses per record. And they're, again, generally similar. So in summary, fee-for-service and Encounter institutional records do have a lot of similarities, but there are differences. Some key differences that we'd like to note. There can be potentially multiple records per encounter. I haven't really talked about that at all yet, but I will coming up. And anyway, so there are these things called chart reviews that I'll be talking about that would be the main driver of there being multiple records per encounter. There is no payment data, like we've talked about already. There is no Medicare provider number, otherwise known as a CCN, included in Encounter records. It is possible to leverage the NPPES file, which contains provider information, and you can link to it using NPIs. Segment 5 kind of includes an example of doing that. Encounter data is far more likely to contain a DRG value of 000 relative to fee-for-service, but you can try and use the derived DRG provided for records other than inpatient rehab and chart reviews. Encounter records have something that fee-for-service records do not, and that is revenue center from and through dates. So that's a bonus. So moving on to the non-institutional encounter files, specifically the physician supplier file, otherwise known as the carrier file, and the durable medical equipment file, or DME file. These are, these are the same file types that you'll see in fee-for-service data as well. So the structure for non-institutional encounter files is similar to institutional in that there's a base and a detail file. In this case, they're called line files. There can be multiple lines per base record, and you link them together the same way as for institutional files using Benny ID, claim type code, and encounter join key. But unlike institutional files, there are no of those lesser used reference files available for non-institutional RIFs. The base segment is similar to fee-for-service claims. It contains these important variables listed here: dates, NPIs, and diagnosis codes. The line file, again, has one line per claim line item, so there can be multiple lines per encounter, and also includes beneficiary information, IDs, line number, and line dates, and HCPCS codes. When we compare the percentage of members with any claim or encounter, fee-for-service to encounter, it's very similar in the carrier file, which is like where you will find physician claims. DME looks like the encounter. It's a little bit less likely to find an encounter claim for a member in the DME file for Medicare Advantage members. Encounter data use the same procedure coding systems as fee-for-service data, thank goodness. CPT, ICD-9, and now ICD-10 codes as of October 2015, as well as the same diagnosis code system, which is ICD-9 and 10, depending on the time of the encounter. So although the same coding systems are used for both fee-for-service and encounter records, the Medicare Advantage organizations may actually have their own coding practices and policies. They do not have to follow Medicare's rules. So when using encounter data, it's important to consider all possible ways a procedure may be billed or coded. For example, evaluation and management encounters can be identified with E&M, HCPCS codes, or there are also some G codes. But so anyway, even if something like that were dictated by Medicare to be billed a certain way, you couldn't assume that Medicare Advantage organizations have the same policies. Again, non-institutional encounter records can potentially have, there can be potentially multiple records per encounter. It's mostly driven by chart reviews, which I'll talk about in a minute. Coding practices and policies are set by the plans, which may cause variation in how care is coded. Again, there's no payment data, and unfortunately, there's no provider specialty code variables in encounter data. So now be talking about chart reviews. It's a very important, unique aspect of the encounter files that definitely need to know and be aware of before you use these files. So in addition to service records, encounter files also include chart reviews. So they're just mixed in to the file. You know, they're submitted using the same format as encounter records are submitted. So they're just mixed into the file. And what they are a way for MAOs to, after they go back, they can perform retrospective reviews of beneficiaries' medical charts in order to identify diagnoses that were not originally submitted by the provider or were submitted in error. Their only purpose is to add or to delete diagnoses from a member's record. So why would Medicare Advantage organizations do that? Well, the diagnoses that are listed for each beneficiary each year have a large part in determining their what's called a risk adjustment factor score. And that score is what determines the amount that CMS pays to the MAO for that member. And so these, the risk adjustment factor and these chart reviews can have a very sizable impact on Medicare Advantage organizations, revenue. And we've provided a few citations here that kind of, talk about that. So what do they look like in the data? Here's kind of a depiction in the table at the top. The first record in the table would be a service record, and the bottom two records are chart reviews. As indicated with a Y in this variable, it's called the claim chart review switch. And so you can tell which encounter the chart review is supposed to be adjusting by looking at the claim original control number on the chart review. So you use that claim original control number and you try to match it to the claim control number to the record that it's adjusting. So when we looked at inpatient data from 2018, we found that 62% of chart reviews in the file linked to a service record successfully, but a large portion of them did not successfully link to another record. And that was either because the claim original control number was not filled, or it was filled, but it didn't match any other record in the file. So for chart reviews that have an 8 in the variable called claim medical record number, that means that that chart review is meant to delete a diagnosis. But the vast majority of chart reviews that we found in that inpatient file from 2018 added diagnoses to a record. So deletions appear to be rare. It's also good to know, well, like the table shows, there can be multiple chart reviews for the same encounter.
And should all chart, in theory, should all chart reviews be at least conceptually related to an existing encounter record? So a chart review can't be done just because the organization feels like this person has some condition that didn't get triggered in any of their encounters, but we'd like to get it in there or whatever.
Yeah, I think the intention is that they should all be in in response to an existing encounter. Can't really explain why some don't link to other encounter records. in
It's kind of a high rate for that.
Mhm. Right. It is. And so, you may want to, if you're wondering, you have data and you don't know what to do with the chart reviews. I mean, you could see, well, so there's no original claim number on the record, but can I maybe look for a claim, an encounter that has the same dates, or something like that. But it's kind of unclear. There's no clear way to decide, what to do with those records. It is, acknowledged in the user guide that chart reviews that do not link to other encounters do exist. And I think the way they phrase it is that, chart reviews like that can only affect a member's risk adjustment. So, yeah, it's kind of a
which
question.
Is exactly the area we're working on. So
okay, great. All right.
So Becky, there was one clarifying question about the previous slide. Someone just wanted to check their understanding of whether N30 was being added to the initial encounter, or N390, excuse me. N390.
Yes. So yes, N390 would be added to the encounter record. Yes, that's correct. It's an addition, and that's because this variable, the claim medical record variable, is blank.
The K219 is being taken off.
Correct. So we did a little bit of digging to kind of get a feel for, how much effect the chart reviews are having. Just did something on a high level using the 2018 inpatient file. We found that 20% of members that had an inpatient encounter received at least one new diagnosis as a result of chart reviews in that file. So it's just based on that one file. And it did vary by plan organization. And we did find that there was one particular organization that contributed 64% of these cases where a diagnosis was added to a member's list of unique codes. So they contributed 64% of those cases while ensuring 26% of the Medicare Advantage population. So kind of a disproportionate effect there. The next highest MAO contributed only 7%. So kind of interesting there. So researchers should consider whether it's necessary to include chart reviews in their that would not be affected by diagnosis reviews. Maybe you are fine with how a provider would have coded the encounter, or diagnoses don't really come into play very much in your analysis. You could simply remove the chart reviews. Would make it a lot simpler to do it that way, but it's something you have to decide for your particular project. The volume of chart reviews can vary by file type. You can see that inpatient is the highest, followed by a carrier file. And here's a table that we provided of our accounting of the chart reviews and that inpatient 2018 inpatient file. So maybe something to reference if you ever dig into your own encounter data and you're wondering, like, well, is this am I interpreting this right? Or it's something to reference. This is just for inpatient, so it does vary by file type, but it's kind of interesting to see, that, yeah, the percentage of chart reviews that we found that linked successfully to the encounter records or other chart reviews. They can also link to other chart reviews. Yeah, you might find that a helpful reference. Oh, and also I'll note that there is a small fraction of chart reviews that actually linked to records in the prior year's file. So that's a possibility too. So although chart reviews are probably the most common way that you're going to find multiple records for the same service, multiple records that are generated around the same service, it is possible that you could find multiple service records for the same service. So when you exclude chart reviews altogether and just consider the service records, we have uncovered some cases of multiples. For dates of submission on or after October 1st, 2015, CMS applied a 5-key edit to deduplicate records. And so records that shared the same value on all the key variables in the key were considered duplicates, and only one instance is kept. We kind of verified that you can see that happening in the data. You can see a large drop off in the number of duplicates starting in October of 2015. So the variables that make up that 5-key edit that CMS applies are listed in the top row of this table. Along with the 5-key edit, we're kind of showing you results of our evaluation of inpatient data from 2018 using 5 different variable combinations. So the top has the most detailed key. The bottom is the least detailed, and it might be an example of something one might consider using if they're trying to consolidate multiple inpatient records into one stay. But you can see that the percentage of duplicates, overall is pretty low. It's a little higher for the one at the bottom, but that doesn't necessarily indicate duplicate encounter records. It just is like, like for fee-for-service data, you can have multiple claims for the same hospitalization. It doesn't happen a lot, but it does happen. So, but anyway, so the other 4 keys, you can see the percent of duplicate records is pretty small, but we did find some according to these keys. So if you are interested in doing some deduplication, it might be helpful to know that the more recent the record, the higher the claim control number will be. So if you thought, oh, I'll deduplicate by taking the most recent record, you would choose the higher claim control number. Like in inpatient fee-for-service data, a state level analysis may require grouping 1 or more unique service records, like I was just talking about. It might be helpful to read chapter 4 in the CCW Encounter User Guide when you're going through the process of how you're going to decide which records to keep for your research. So what is the most common reason to find multiple records for a single service within a single file in the encounter data? right, so looks like 80% of you say chart reviews and 20% say service records. I think that it is, you know, definitely chart reviews are going to be more common than duplicate service records. You know, definitely in the inpatient file and the carrier file, the others, it may not be as clear, but yes, you know, there are a lot of chart reviews. The inpatient file from 2018, I think it's 30% of all the records in the file are chart reviews.
And 64% of those, more or less, are from one MAO?
Well, what I talked about earlier was when we counted the number of beneficiaries who had unique diagnoses added by chart reviews, that was driven by one particular MAO. So yes. So yes, I'm not quite sure, you know, we didn't analyze like how many chart reviews in the file were attributable to certain plans. That makes sense. But anyway, that would be interesting to look at.
It probably tracks to at least some degree, whether it's exactly that same percentage.
So in this last part of the segment, just want to go over some key considerations for your research files that you might want to keep in mind. So this is just a general rule that applies to both Medicare Advantage and fee-for-service. If the field impacts payment directly or indirectly, its quality will be better than if it doesn't. You know, so for fee-for-service, we kind of know what the rules are, but unfortunately the rules may vary by plan or package for Medicare Advantage. So, you know, it's a little bit harder in that way if you're using Encounter Data, because MA plans are not obligated to follow CMS processing guidelines. Excuse me. So the structure of Medicare data is complex, which is a big reason why we have these workshops. Fee-for-service contains final action claims only, while MA in the user guide, it will describe the records in the Encounter RIFs as final action. You know, there still is potentially multiple records per encounter, mainly driven by chart reviews. So it's definitely important to keep that in mind. For both types of record, services will be appear in different research files depending on the service setting. For example, services during an ED visit could be found in the outpatient file or the carrier file, as well as I think even in the inpatient file for fee-for-service.
Results in admission, it'll be in.
Yes, yes, right. So a full assessment of a member's care may require multiple files. And yes, so, and you need to keep that in mind, you know, to avoid counting duplicate services that you may have to deduplicate in some manner. You also should keep in mind, you know, that you need to know your files before mapping out your analysis, because sometimes MA beneficiaries will be in the file, sometimes they won't. Sometimes the file will contain both fee-for-service and Medicare Advantage beneficiaries, like in the MedPAR. So these are all important things to consider in your analysis to avoid counting duplicate services. Also think, are there changes in benefits reporting or coding that could impact your observed variations or trends? Like Nate was talking about earlier, you know, there can be legislation or policies enacted that could cause changes to the patterns you see in the data. And those patterns are not driven by necessarily utilization changes, but actually policy changes. You know, you need to be aware of like changes to how the coding systems that are being used, like the transition from ICD-9 to 10 in October of 2015. And remember that Medicare Advantage companies do not have to follow Medicare's policies, billing policies. They may have their own. Part D coverage enrollment can vary, and something to be aware of. You know, some services are covered by Medicare Advantage that aren't covered by fee-for-service, like dental and vision. And also there can be changes in CPT codes over time. So when getting started on planning out your research project, we think about it in 3 key steps. First, you want to define your population. Those would be identifying members that are going to be eligible for your particular study using, you know, demographics or coverage information that you would get from the MBSF. You want to define your events. Common ways to do that are identifying particular treatments, you know, maybe all records incurred after a certain event, you know, payments events. You need to ensure that all of the relevant codes are included when you're doing your study, so that you're, and you also need to ensure that your encounter data are deduplicated. Those are important things to make sure that you're measuring your events accurately. And finally, define your adjusting variables, like comorbidities and demographics. You want to confirm that your important covariates can be found in the data. Finally, we're leaving you with some additional resources. These the blue ones with blue underlines have links associated with them. And, you know, another possibility is to, you know, make a connection in a hospital or clinical billing department. You know, maybe even cold call them and see if they're willing to talk to you if you want to know more about how they bill particular events. So, questions?
Sorry, we've had quite a few questions. Yeah, a lot of people are interested in the chart reviews. And so one of the questions is, you know, if you're interested in something, if you're trying to measure something using diagnosis codes, do you then for sure want to include chart reviews in order to be comprehensive? Or what is how should we approach that?
Yeah, well, that's a great question. You know, maybe stuff you can add to what I say here, but you know, the way that providers code things, and so providers, the encounter records, we assume, have the codes that were submitted by the providers. So, you know, I don't know why their process would be different when they're coding a Medicare Advantage claim versus a fee-for-service. I kind of doubt that billing departments are aware of that. Well, actually, I don't know that. But anyway, so if you feel like, you know, the way that providers would have billed the encounter is enough, you know, accuracy for you, then I think using just the diagnosis on the encounter records would be adequate. So it's kind of a judgment call. You know, we do see that chart reviews are adding unique diagnoses to patients' records, but there's questions about upcoding. You know, upcoding by MAOs. So it's kind of up to you to kind of decide how you want to handle it. I don't know, Steph, if you have anything to add there.
Yeah, I think broadly when we think of, you know, administrative claims data research, and we'll talk about this in the final segment, but, you know, these are data that are collected for administrative purposes for the payment of health services. So when we're trying to infer whether or not someone has a diagnosis, we're relying on what's reported on the claims. And that's why we have some claims-based algorithms to try to help us out. With Medicare Advantage, we now have the addition of chart review records. Someone asked about, well, if you're trying to compare fee-for-service and Medicare Advantage, then maybe it's a better idea to leave them out. Possibly. Again, the way that diagnoses are going to show up on the claims are going to be somewhat dependent on how the provider is being paid by the managed care organization. It's also whether or not we see a chart review is going to be dependent upon how maybe aggressive the managed care organization is in doing their those chart reviews. So we certainly, they're good questions to ask, I would say, about how do you want to handle them, especially depending on your comparison population. And let's see, I think there was one other kind of question, like it's hard to say you should always exclude them, you should always include them. You might have to think about your study aims, but these are the right questions to be asking, I would say. And also, you know, plan variation might also be a little bit of a trick if you're looking at the encounter population globally and you're including chart reviews. Just know that there may be variation in plans in terms of the submission of chart reviews. So all things to look at when you're finalizing things. And then similarly, so can we speak to the validity of the derived DRG for Medicare Advantage inpatient encounters and how accurately do they map to DRGs in fee-for-service claims?
Well, I know that CMS uses a software package to infer the DRG, but I would think that it would be pretty reliable, but I don't know enough about how DRGs are coded, like if for fee-for-service, if they are sort of like determined during the claim processing, or if they're entered by the provider. Maybe Steph knows a little bit better, because if they're sort of like created during claims processing, then I would imagine that the software being applied to the encounter data would create similar DRGs for similar types of records between fee-for-service and Medicare Advantage. But
yes, that's correct. So CMS, I think providers do submit a DRG code, but what we see is what CMS has calculated based on what was the diagnosis and procedure and other information that's used to calculate DRGs. So yeah, the derived DRG should be similar. Now, that being said, if you're being paid by fee-for-service, you might know in a prospective payment system, you might know how to code something to get the DRG that you want. And maybe if you're being paid by a managed care organization and it's less dependent, you're not being paid prospectively on a DRG basis, that might inform a different way of coding diagnosis and procedure codes. But I think on balance, probably the inclusion of diagnosis codes will be similar. So, and the derived code is, yeah, the same software.
I did see one question that was kind of like, I don't understand how chart reviews can create duplicate, service counts. So say you're basing your service counts using like, all records that have, a certain diagnosis on it. And you were, just doing a count based on that. Then your logic may not, if you don't have anything addressing chart reviews, you may be counting the same service twice. If that makes any sense. I hope that helps a little bit.
Yeah, thank you. There was one kind of specific question about in the carrier file, and I don't know if you've looked at this at all. There's a line latest claim indicator on the line file. Have you looked at that at all? Would that assist in removing duplicates?
I have not looked at that. That would be interesting to dig into that. I will put it on my list. Again, yes, it's a lot we don't know.
Yeah, and then I think another couple of questions have come in about supplemental benefits like vision and hearing, and whether we see them. I said we do certainly see them, and then how well are they being reported? I think that's a little trickier, but go ahead.
Yeah. I think, we have not analyzed that, so it's really hard to say how well it's being submitted. I mean, it could be vary by the company that's submitting the records. Some may, their members may have coverage, but they don't submit them to CMS, and others may be, submitting them. So it's really hard to say how complete that type of encounter is going to be in the RIFs at this point. That is definitely something that we would like to know more about.
Yeah, I'm trying to look through them to see. Please feel free to ping again if there's something that we've missed. I guess one question was whether we've looked at the number of diagnosis codes on average between fee-for-service and Medicare Advantage. I don't think we specifically had that, but
I think that let's see, there was.
Yeah, I think you did.
We did for.
Oh, there we go. Thank you.
Institutional records.
Mm-hmm. So you certainly see some differences. Again, even with fee-for-service, I'm going to be talking about hospitalizations later, but the number of diagnoses that are billed on hospitalizations does impact the payment to the provider. So we do see also a large number of diagnoses for, it's not terribly unusual to have all of the diagnosis codes filled in order to get, to make sure that payment is accounting for all of the complexities of the patient. So, yeah, you might worry about the risk adjustment piece, but what's on the encounter hopefully will be mostly what the provider is reporting to the managed care organization, and then the chart reviews are going to be in addition to that. That will be the additional piece that the managed care organizations want CMS to be aware of.
Becky, this figure is prior to chart review or excludes chart review?
I am not sure. I will try to find out for you right now. Oops. Let's see here. Oopsie. Sharing my screen.
And then there's a, while you're pulling that up, there's a question about, it does look like there are more median diagnoses in home health encounter files than in fee-for-service. And I haven't looked into home health as well. It could possibly relate to, you know, differences in payment adjustment according to diagnosis. And then the other question was if there's if you're relying on final action claim indicator, will you pick up chart reviews if you say, yes, I want final action claims?
No, final claim chart reviews have a blank in that field. So I believe it's yes, they're all yes for you know, service records, and they're all blanks for final action records. Either that or they're no's for chart reviews. Sorry, did that make sense there? So I'll dig into your question about whether the charts in the presentation included chart reviews or not. I'll dig into that and get back to you this afternoon.
I think we've got time for a couple more questions, if well, maybe one more, if we have any. Otherwise, we can plan on breaking for lunch. If it'll take a while, Becky, we can get back to people in the afternoon too. And we will return at 1 p.m. Central Time. I know that maybe is a late lunch for the people on the East Coast and early for the West Coasters. But when we come back, then this afternoon, we're going to be talking a little bit more about what does it look like to try to measure hospitalizations. And we do compare the MedPAR and the Encounter inpatient file in that segment. So stay tuned for that. Peter will also be talking about using the carrier in the outpatient file to measure some specific things, and specifically comparing that to HEDIS plan level data. And then we'll finish it off talking about how can you think about measuring spending, and how can you just overall in general think about these. And then will later sessions address whether differences in the availability of inpatient and outpatient data in fee-for-service are related to data issues or differences in service use. Not as much. We will be looking at what we find in the files and comparing them to other data sources. So we can kind of see that in terms of, maybe the managed care organizations are doing a really great job of keeping people out of the hospital, and that's why you see fewer inpatient stays. We don't really have much on that at this point, but I'm looking forward to seeing a lot of research about this.
I had a quick question. Could you repeat that part where you said how to remove the duplicates? Like I couldn't hear it.
Oh.
So for duplicate, like
from the charts. Yeah.
Sorry?
From the chart review.
Oh, okay. Yeah. So you can use a variable called, let's see, chart review. What is it called? Sorry. I'll bring up my screen again. Hold on a second. Oh, I guess I don't want to do that. There's an indicator for chart reviews. There's a variable that you can use. So you would discard all the chart reviews to get rid of those. But to evaluate whether there are duplicate service records, you might want to create a unique key using the variables that we included in, we have some examples of various keys on slide 36 that you could use to deduplicate duplicate service records. Does that help at all?
Yes, thank you.
Yes, you're welcome.
There was one final question maybe we can talk about when there's a claim medical record variable with the value of 8. It might have a repeat of an ICD code that was in an encounter service record. So then the question is, how should you handle that? Do you include all the diagnosis codes of that chart review on the encounter record? And I think I was writing that actually indicates a removal of of a diagnosis code. Likely, so they're more rare, but likely that when they did the medical record review, they couldn't maybe find enough evidence of that diagnosis code, or they needed to replace it with a different one, perhaps. Depending on your aims, whether or not you want to go back then and remove that diagnosis code from the encounter, you could certainly do that. If you're comparing with fee-for-service doesn't have the similar going and checking the chart review or going and checking the medical record. So how you want to handle that is a little bit dependent on your aims, I think. It's not a terribly